how do you routinely do surveillance, and is the brain a different category?
So if you don't have deposits in your brain, I'll do an MRI of your brain every 6 months. If you do, I'm going to do it as frequently as I scan the body. And I tend to scan the body somewhere between every 2 to 3 months. If it's in a clinical trial, it's mandated, so we don't have any flexibility on that. In terms of how I scan, so here, I was kind of touching on health economics earlier. My prejudice is I actually like PET scans, and I have very good friends who will argue till the cows come home that, you know, I have no evidence to support this. But we're looking for that early progression, that early little clone, that one bit of the cancer that's doing something wrong. And you can see that much quicker where you might be able to intervene with a local therapy like radiotherapy with a PET scan. If the insurance pushes back, then the other thing I'm doing is I'm marrying it with some serum-based tumor markers. So maybe about 50% of people with lung cancer will express something in their blood that you can measure, like CEA. It's a bit sloppy. It's like towing a car with an elastic rope. But there's a vague relationship between, you know, what it's doing and what the cancer's doing. So if you're having to do CT scans because that's all your insurance will allow, but your tumor marker's going up, I use that as leverage to say, I need the PET scan now.
So that must be why you were exiled from the UK.
That was exactly it. Yeah. And then there was the scandal, but we're not going to talk about it.
Does Medicare let you do?
Medicare is actually the easiest insurance to work through. It's
well,
the government.
But the restrictions are coming that there will, you know, they are moving towards 4 lifetime PET scans. And yeah, that's where things are going. I don't know if, but there's, in fact, that's an ASCO initiative, is to try to reduce PET scanning for routine surveillance. I think there is a difference. I think it's important for people to recognize that even among people with an expertise in this, there are differences in practice. I've come towards doing more brain surveillance in ALK positive on crizotinib as the leading edge of where you would want to do that. I don't necessarily do that in other settings for metastatic disease. I don't do a lot of routine PET scan surveillance of patients. I'm intermittent on serum testing, and my concern is that we do need to differentiate, and this is an art or a black art of it, is, you know, the clinically significant progression and this acquired resistance is a gray area of, we don't want to discard any treatment too early, but we don't want to miss the boat either. And I think that's the challenge of it. Is I think that we are all resonant with what the patient would want, in terms of, we want our patients to live as long as possible, do as well as possible, but knowing that we have a limited number of shots on goal at this point, we don't want to discard anything too early. I think that's the challenge. My concern with PET scans is that it's like changing lanes in traffic, LA traffic, on the freeway, and, you know, it's a traffic jam, and you think, well, that lane's going a little faster, you change, and it's just doing something to do something. And too often, if you don't see any change in the CAT scan, nothing's growing, but the SUV, the standard uptake value, level of PET activity goes from 4 to 5, I see a lot of people get frantic and make a change. I don't consider that clinically significant progression. I think if it's real progression, you need to feel it or you need to see it. And if you need to look under a rock, you're really borrowing trouble. And I don't think we do that. I think that the serum tumor markers are something that I do use as a modifier to adjust my level of vigilance or reassurance. I mean, if you see someone had a carcinoembryonic antigen, or CEA, which is not something that is a standard thing to do. It is, I think we can all agree, it's a squishy variable, and some very reputable places do not use it at all, and that's not wrong. If you do use it, I just think it should not be the reason to change treatment because a blood test shows the number going up or down. But if someone's goes from very high to very low and you're checking it regularly, it's easier to do that than checking CT or PET every visit. And if you see that number staying low, you can feel pretty reassured by that. at least if it was high. A big limitation of it is if it wasn't elevated abnormally before, it doesn't mean anything.
Yep.
But it's a potential modulating tool for, at least in my mind, the level of vigilance. But I do think we struggle with the distinction between what is any detectable progression. If you squint, you can see that it's measurably 1 millimeter larger, versus this is real trouble. We need to change approaches. I think that's really the issue.
Mm-hmm. Yeah, I would agree with Ross. I do something very similar, although we don't follow PET scans. We would not get those approved in Massachusetts for sort of surveillance purposes. I do surveil the brain every 6 to 9 months in all of my ALK patients. And we don't follow serum tumor markers.
Right.
I guess one thing I would emphasize, though, is that I have heard quite a bit in the community, and even in some large academic practices, that they start a patient on Xalkori and then they just set them up to see them every 3 months with scans, which I definitely do not do. We just can't follow patients only. I don't know what you do, but I see them every month to check in, even if everything's going great. But to go every 3 months with no visit, no lab work is probably not the best way to surveil a patient.
You do have a sense that with at least the EGFR inhibitors, and my sense is also with ALK as well, the longer and deeper the response, the longer you tend, the better you do, the better you do, kind of. I don't know if that's really borne out, but I tend to lengthen the interval, not to 6 months or anything like that, but I start out with a closer, partly
Right.
for looking at monitoring liver function tests
That's right.
and toxicities, but also I feel a little more comfortable letting people go a little further.
Yeah, I'm primarily
visits.
talking about the beginning, because I hear about this
Yeah.
a lot, that patients are just being seen just once every 3 months in
Yeah.
the very beginning,
No,
which is just
no.
not enough.
No, I mean, we heard an example of somebody who went on it and progressed at 3 months.
That's
so
right.
you've got to know you're a responder before you can start to get any relaxation at all.
Yeah, you had a question.
How do you advocate for someone when you have an oncologist who says, well, everything's fine, there's no evidence of disease from the neck down, we do yearly MRIs, and that's how we roll, that's what we do. And she says, no, I want it every 6 months. And so then I'll join her at the next appointment, and maybe that'll be enough. But, you don't know what is your ace in the hole? What do you say? Is there a magic word? It seems like she has the insurance that would do it. So,
Well, I would say it's important to recognize that this is still evolving, and it's not, and I appreciate that there's a heterogeneous practice pattern, and I think it is something that has led me to change my views over time. But by extension, I would say that there's still not definitive evidence that it needs to be 6 months or 3 months or anything like that. And so I would offer that latitude, at least in your way of thinking, if not expressing. But beyond that, I would say, I think it would be potentially effective to say, well, I attended this program, and Dr. Shaw and Dr. Camage, who they may know, are strongly advocating this. And that's the kind of thing, I mean, in the absence of actual evidence, we have to go with judgment and experience, and we largely defer to the people who have more of that experience. So it's not, all I'm saying is it's not nefarious. The guidelines don't say you need to get it every 3 or 6 months. And so it's not that they're just being obstinate, but that, if anything, I think could sway people, it's just that, hey, this is from the people who really lead the charge. This is the way they're doing it. Just saying. And I don't know if you.
I mean, I think that's fair. You want to keep. You want all the friends you can get, so you don't want to alienate your oncologist. But if you can gently educate them, then that's good too. So there are. We published a couple of papers where we're looking at the failure rate in the brain as opposed to the body. So it's interesting when you think about that. So when you see that data that says the median progression-free survival, the time it takes for the cancer to grow, is like 9 or 10 months for crizotinib, remember that nearly half of those cases are just progressing in the brain. So actually, if you zap that with radiotherapy and keep the drug going, your duration of benefit in the body is actually much longer. So don't fixate on the numbers too much. But you can get those published papers.
Yeah, and the other point I'd make is just as a corollary of, the field's changing quickly, and we all, I started Grace to get information directly to you guys, and I know there's a lot of great information in other places like Inspire, and you're sharing it among yourselves, and that's amazing. The reality is no one brain, certainly no general oncologist can keep up with everything that's happening, and that doesn't make them an idiot or wrong or anything like that. I mean, we are still, even though we specialize in this, I have learned a lot from people bringing it back to Grace or coming to me in the clinic, and it's humbling, and I think it's more humbling if you treat a lot of things. But the reality is we are going to be living in a new era where patients have the potential to know more about, especially a very narrow field, than their doctor. But that my point is, that's great, and it doesn't mean that someone's dropped the ball on the doctor's side, because it's just, yeah, no, and I know you weren't saying that, but it's more just a commentary that as there's so much information out there, no one person can have it all, and we should just try to pool everything together.